Pleasure to be able to introduce Dr. Steve Glassman. If we can get Dr. Glassman's talk up. Dr. Glassman is at Norton Leatherman and leads the spinal group there. He's been a major person involved in the American Academy of Orthopedic Surgeons and has helped really bridge the gap between the neurosurgical groups and the orthopedic groups, along with other colleagues. And so, Dr. Glassman, pleasure to have you here.
Good morning. Thank you for the opportunity to talk a little bit about ASR this morning. So those are my disclosures. As Mo pointed out, ASR is a partnership of AAOS and AANS. It started in 2019, really started enrolling data in 2021. The primary rationale was to support evidence-based quality improvement in spinal surgery. We'll talk a little bit more about it. It has a more broad national goal as opposed to the more higher acuity things that you see in registries like CSRS or ISSG. And our initial accomplishments have to some degree been more on the political side than the data side. They've brought together the two organizations. That's been valuable from an advocacy standpoint. And we've been able to start to get more broad support around data integration. As an example, ASR ran a meeting the day before this started where we were able to bring together national payers and FDA and hospital systems and Joint Commission and DNV. And that would be hard for any of the one organizations to do individually. So we think that the power of bringing these two organizations together is going to be substantial. The registry has been growing. There are now over 250,000 patients in the registry, about 180,000 lumbar, about 80,000 of cervical cases. So it is looking to be broad across the country and represent standard clinical practice as well as tertiary care centers. But one of the things we've really learned with a lot of pain is how data for spine surgery is really problematic. One of the ways that registries often pull data is by ICD-10 code. But as anyone who's looked at that knows, in spine surgery, ICD-10 code bears almost no relationship to why we do the procedures. And if you look in a hip or knee registry, there may be 5 primary diagnoses, and almost all of them are osteoarthritis. In spine, in the cervical registry, there are 215 primary diagnoses by ICD-10 code and almost 300 lumbar codes, and then a vast array of procedures and implants. So it makes the data very hard to analyze, and we try to look now more critically at how ASR can improve that flow and then the utility of the data. So a really important thing that's very hard to do is to define the input better, to try to bin these things so that they're meaningfully represent why we're doing the operations. And the way we've done that most successfully is by OR smart forms, where the surgeon has to define, Tony was talking about this, why they did the operation. All of our patients carry multiple diagnoses, and no amount of AI can pull from the EMR why you did the operation. But that's input that's invaluable, and we are looking over the next year to go to the only data that gets really into the evaluation subset is data that carries this information. This is a publication that we did that demonstrated how that improved the granularity of the data. Patient-reported outcomes are another important piece of this. For a broad national registry, we have about 20% of the patients with PROMs. That sounds terrible. It's not good compared to high acuity study groups, but it's by far the best of any broad national registry. It allows us to do things like to look at how people are reaching MCID thresholds across the country, and starts to be the basis for people being able to look at their own benchmarking data. We also have CMS data integration, right? It's the only registry that's patient identified linked to CMS. And this is a look at how that might be valuable. This is 8,000 spondylolisthesis cases. And you can see if you look at only the ASR data, you see a CCI for risk stratification 3.26, But if you take those exact same patients and pull their data from CMS and ASR, it bumps up the risk stratification. It gives you more accurate assessment of the acuity of your cases. Also, for complications, in this case, readmission for infection, it reads as 1% in the ASR data, but you link it to the CMS data and you get 1.4%, which it reflects the fact that a lot of patients have an operation one place, but their complication treated somewhere else. So it starts to improve the quality of data substantially. So if we look at growth opportunities, facilitating data integration is important, optimizing data utility is important, and we're going to partnerships with organizations and different pathways to enter the data to try to start to get over the hurdle of how hard it's been for IT departments and individual hospitals to really make this work effectively. By far, the most important piece is surgeon engagement. The places where we have surgeon champions who are engaged in this have been our successful centers, both big, large, tertiary, private practices. So I would really encourage people that if you want to be involved, a surgeon champion is important, not just saying, I'm going to get my IT department to do this. And then finally, the goal is to have granular data at volume. And those are hard things to do, right? When you look at what AI is going to do, it's going to crawl the databases. But if what's in there doesn't reflect why you do procedures, it's not going to give valuable data. This is not a substitute for things like the CSRS registry that's going to look at specific questions with acuity. This is something that might give you a broad national signal that would tell those other study groups what are important to study, where are we having problems. So I think it's important not to conflate the value of these different efforts because they should be synergistic, not competitive. And I think that is something that we're learning as we get into this more and more. So thank you very much.